Is 400 milligrams a week of testosterone sustainable for life? This is a very important question, and I've had so many men come to me on this dose of testosterone, blasting and cruising. It's so common that this is this dose. You know, in the old day, it used to be cruising on 250, sussing on 250, 1 cc a week back in the 70s and 80s. And now it's very interesting that it's inched its way up, if not more, to a blast and cruise dose of about 400. And so many men have come to me over the years and said, Doc, you know, I love this dose. Is it sustainable, Doc? What can we do? So this is why I'm bringing this to you today. And I'd like to discuss overall what may happen to the net health effects. And I'll let you know what I've seen, and I'm going to discuss point by point of what I actually do medically for men like this. So first off, we have no data. We have no prospective randomized trials. We have no real medical data on outcomes of what may happen to men that are living on this super physiologic dose. We actually don't even have data of any long-term type of outcomes for even TRT data. You know, it's really all anecdotal, and it's more meta-analyses, you know, so that's what we have. So I could tell you that I've seen thousands of men on this dose, even more, come to me, and they're men from the 20s into the 60s, you know, 20-year-old men up until the 60-year-old men. And the vast majority of these men are just hobby powerlifters and bodybuilders. Of course, I've taken care of some of the top guys in the world, but the average guy here is, you know, this is what I'm basing this on. This is really the meat and potatoes of a practice like this that I've been involved with. So first off, let's look at the numbers. You know, so when you're taking 400 milligrams a week of testosterone, what does it look like on the lab? Quick pause a second. If you're watching this video, chances are you're on testosterone or maybe even steroids, and you're concerned for hair loss. So am I. So what's going on is that testosterone from your testicles, naturally, or from exogenous testosterone with injections, even steroids, can make you feel phenomenal and great, but it definitely can lead to male pattern balding. A lot of genetics on this, guys. There's a lot of other factors involved, but DHT, the conversion of testosterone to DHT, is absolutely fundamental. Now, you guys know, I don't like the systemic DHT blockers like finasteride and or dutasteride because they cause sexual symptoms, not on all men, and not even on men that are just on these medications alone, but even for men that are on testosterone and steroids. The brain, guys, the sexual center stimulated by androgens is incredible, and I love it, and I know you guys love it too. So my number one recommendation is going to be shampoos. You got to see the link here. There's two products, shampoos and topical agents. These products I'm recommending, in my opinion, are the absolute best combinations of ketoconazole with other specific agents for this shampoo. You got to see these products. Check the first product lines for the shampoo and the topical application. I'm going to watch this in myself, guys, and I've heard this stuff is absolutely amazing for my patients firsthand. So thank you so much for trusting me with this, guys. You got to keep the hair strong and healthy. You're taking 400 milligrams a week of testosterone. What does it look like on the lab? You know, if you go to the lab 24, 36 hours after injection, obviously it's going to be dramatically different than if you go to the lab the nadir, you know, the day 7 or even 5 after the injection. But kind of if I can give you an average of what it looks like, the total testosterone will really look like about 4,000 or even whatever the max limit for that lab assay will be. A lot of times it will say greater than a certain level, like 1,500, depending on the assay, you know, that you're looking, what lab you go to. So, but it's not uncommon to see 4,000 if indeed that lab can measure that high, and that's nanograms per deciliter. On the free scale, if you're looking at the scale that goes up to about 155, this is in picograms per milliliter, it's not uncommon to see 350 to 500 or so. Again, there's limitations on the technology. So that gives you kind of a ballpark of how super physiologic this is. Now, what are the health consequences? What is going to happen if you live on this dose? Because we have no data for this. So, and one of the questions that so many men ask and scientists are looking into is, what are the effects actually on the skeletal muscle? Can the skeletal muscle sustain that, and are you going to maintain anabolism? And there's a lot of different things with downregulation in the muscle receptors, and that's why steroid-using men are so amazing that over the years they come off and they cycle. They even have techniques for upregulating musculoskeletal receptors and androgen receptors. So apart from the muscle building, I'm going to go into the consequences on the overall health consequences as an internal medicine expert. So right off the bat, let's start up with the brain. Let's talk about the libido. So with the central nervous system, with that type of exposure sustained, for even a year or 2 or 3 years, what happens? Some men can maintain a great libido. I think it's very true that a lot of men come to me, they've been on 250 to 400 for maybe a couple years, and the reason why they can't go down is because they love the libido, and they try to go down, and they have problems. So let's talk about that in the end. Also, what happens is, remember, this dose of testosterone is rarely used isolated. It's used in addition to other androgens. And depending on what androgens you're using at Blast and Cruise, if you've had exposure to tren, right? So you see my videos on this, that's going to be incredible for what it does to the central nervous system. Remember, up in the libido, that's the central nervous system. So most men will feel good for a while, but even on this level, when you see those super physiologic, especially with it's really the free testosterone, you'll see that they actually have moodiness, and they have changes, and they have libido issues. And this is, apart from estrogen levels, and we just don't understand this. It's really incredible. Again, some men can maintain a libido, but my opinion is at a certain point on that dose, it's not sustainable for the libido. So let's keep moving on that. And this is, again, these are reasons why a man will need to never get off testosterone if he can't, but to lower the dose and find that lowest effective dose. And that's what I've provided for the world and for my patients, of course, all ethically. Next is fertility. I have good news on the fertility front. You're going to need medicines. You're going to need stimulatory medicines, urologic fertility medicines, and maybe a good urologist or a physician that, like me, knows how to utilize medicines like HCG and or Clomid. And one physician is Dr. Lipschultz. And you can see the data that we all use, fertility urology doctors. I'm an internist, but I use fertility urology data, and we see that we could use up to 3,000 units every other day of human chorionic gonadotropin by itself over the course of months. And if we need more horsepower, I say you can add in Clomid 25 milligrams every day. And when you look at the outcomes on that, there are studies on this from Dr. Lipschultz's perspective. It's been incredible how you can regain fertility for men that have been exposed to sustained levels of androgen. So that's good news on fertility. But again, if you've never done testosterone, you should not consider doing testosterone just because it's possible to regain fertility. Some men will not be able to regain fertility. And ethically, just because there's a possibility of rehabilitating or helping a man, it's a lot of work. There are side effects, and it's not ethically correct to just say, hey, you can do this because we have these options. So I want you natty guys to think about that. There is going to be a lot of work to be done if you go on testosterone and steroids. I just leave the question to you. Is it worth it for you? You have to make that decision. Next, central nervous system, we're still up in the brain. 400 milligrams a week of testosterone with its also downstream conversion of estrogens and DHT and pregnenolones and progestins and this whole 9 yards What about anxiety? What about underlying mood disorders? So that's a big piece I see all day long. My nurse gets the questions and the calls about anxiety and mood disorders. Now, this is very complicated. And that's a reason, again, are you on too much testosterone? Is 400 too much? And I think so many men will have anxiety, general anxiety, acute anxiety disorders, superimposed on top of chronic depression and mood disorders, depending on what your underlying physiology and what you have underlying. So that's why you need to be really in contact with your health and your healthcare providers. And that's why the app, the AnabolicDocApp.com, is here for you to have access to me all over the world. Next, let's get out of the head into the trunk here, cardiovascular renal. So I'm going to call those things together. So it's cardiorenal syndrome. The heart and the kidney are very fragile because there's an endothelial tie to them, where that inner wrapping of the arterial bed from the heart itself and the vascular system into the kidney itself is so susceptible to damage from hypertension and from intravascular edema and LVH, left ventricular hypertrophy, myocardial infarction, which is heart attack, stroke, of course, acute coronary syndrome, which are things that are just shy of that, where you have chest pain and you present. This is common for people, not even steroid users. You go to the hospital and you're having alterations on the ECG, maybe the tombstone elevation. This is ST wave MI, or maybe you're having a condition where they're not sure and you go to the cath lab and you have a blockage or a transitory blockage. This is called acute coronary syndrome. So that amount of drug, 400 milligrams a week of androgen, testosterone esters, will certainly affect your endothelial bed. There's no question. And the mechanisms are mediated through intravascular edema, effects on the renal system, the kidney system, the myocardial system itself. So I have a great example though, so I have a powerlifter, and this represents many men that have come to me over 20 years. He comes to me and he wants to keep powerlifting. He's in his late 20s to 30s, maybe even older. And he's living on 250 to maybe 400 milligrams a week of testosterone. Of course, I do my best to try to get him off, and he may not want to come off. So, I can tell you that we've had success treating men than protecting them, and that's what I'm here for. He's making his own decision, and I'm certainly not prescribing that level of testosterone, but so using medications to protect this cardiac system, so hypertension medications, depending on the individual, ACE inhibitors, ARBs, right? And now we're looking at being careful with statins and understanding if you have plaque in that atherosclerosis in your coronary artery bed and throughout your body. And what can you do about that? Statins and oral steroids are never going to go hand in hand. Be very concerned and careful with that for the effects on your organ system, the liver system. So we have to talk about PCSK9 medications, which I'm prescribing for some patients, and I have in the past. And this is Repatha and Praluent, and I have no conflicts. I don't work for any of these companies, but I'll tell you, I'm here to give you information. These medicines are absolutely fascinating, and they have much less side effects, if no side effects. There's also Vascepa. Again, I'm going to tell you these medications because that's where I'm at now. So can you have a powerlifter using super physiologic androgens on his own where he is protected with his vascular system? There's no studies on this, but it's going to be common sense, and it's just harm reduction that if you maintain a normal or more normal blood pressure and you protect the kidneys and the heart, this is an ethical divide for me. And then we have medications that we know can work, and I'm talking about PCSK9, I'm talking about very cheap and commonly known and easily accessible medications like ACE and ARB medications, and having healthcare providers understand how to give this to protect a man while he's going through this period of life where he's searching his soul and enjoying using androgens needs to be protected. This is 100% ethical divide, harm reduction. So moving out of the cardiac system, which 400 milligrams a week for years is going to have effects on your heart, left ventricle, maybe even the ejection fraction, which we see commonly, which is lowering that, which is going to be leading to heart failure. Multiple mechanisms, again, looking at the kidney, we see men coming in with steroid use on variable levels, having focal segmental glomerular sclerosis. You have to look at the protein and blood in the urine, you have to look at that. Your heart, you have to put it together with brilliant internal medicine doctors that I work with and I refer to, cardiology doctors and nephrology doctors, hematology doctors all the time. So also in this front, we have to talk about the hypercoagulable state with deep venous thrombosis, thrombophilia, pulmonary embolisms, and having increase in red blood cells. So many Caucasian men are going to have this, and not that African American men won't have this and other ethnic men, but it's very pronounced with European ancestry. 400 milligrams a week, just 200 milligrams a week, you're going to see increased red blood cell, androgen-induced erythrocytosis that can lead to that very concerning polycythemia. And I could tell you, just dumping blood over and over and not looking at iron studies is going to be a big mistake. You have to really understand the interplay here. So hypercoagulable states, we have to move out of the heart and the kidneys now into this global hypercoagulable state. Again, that's where you're producing a clot, and if it's on the venous side, it's a DVT, and it can lead to a pulmonary embolism. We could see it's very complicated in some of the bodybuilders over the years, having amputations and even death, and it's just very complicated. Here's what's going on. So with European ancestry, there's two gene mutations that are very prevalent. Factor V Leiden is 3 to 8% of all European men, European ancestry men, are going to have a carrying state for this that could be pronounced and brought out just by being on androgens. That's why we do see an uptick, although slight and variable, for men that are on TRT for DVTs. It's very true. We've known it for years. I think we're getting down to, from my perspective, where these risks lie. So the other one is prothrombin gene 20210A. That's another factor too. So we see this, again, I see this commonly when we work with men that have had androgen exposure, even lesser degrees of 400 per week, and then we end up working after a DVT or pulmonary embolism or some insult with hematology doctors, and they're checking for these things. So you don't need to just check for these genes, because you're going to find that you may be positive. What's your family history? Do you have a sister, a brother, a mother, a father? Grandparents and uncles and things we're not so concerned with. It's primary relatives. If you have that in your history, you're going to want to be concerned for taking too much androgen. You're going to want to work around this. So that's very important right there, that whole hypercoagulable state. Lastly, as I'm moving down from the head to the body, I do this in my consults with all my men, is the prostate. You know, the fertility testicles are going to be atrophied, especially on 400, and I said you could work around that. You can with HCG and Clomid. We have Brevell, Ovidrel. These are expensive, and depending on where you are in the world, you may have access to some of these recombinantly produced analogs of HCG and FSH, and LH. So the fertility urology, get down to the prostate. This is very true. So when you're going to be exposed to decades or even less of, even 200 a week of esters or testosterone, not to mention maybe 400 or more, your prostate is going to enlarge. There's no question. It's affected me. So, but first off, we differentiate cancer. So cancer of the prostate, thank God, the data is not shown an uptick of the incidence of prostate cancer being exposed to androgens. And you could check all this, guys, and you could talk to urology doctors. If they're up on the data, they'll see it's true, but it doesn't mean it's not going to affect your prostate and enlarge it. And again, you always have to worry about prostate cancer in there, especially when you're getting older, and that's 40s or older. So You have to have vigilance and monitoring, and it has to be digital rectal examinations, PSAs, and then sometimes you'll have a urologist may want to even look at an MRI. This is cutting edge information. I love to use my urologist for this. Love these guys. Very good for the prostate. No one's going to be better for the prostate than a board certified urologist. They're surgeons, remember that. They're physical doctors. So now what medicines can be used? Love lowering the dose, 400 a week, I think is going to be probably not sustainable. Again, for the prostate, everything else I managed, you bring down to maybe 200 or even 100, and then you still may have BPH, non-prostatic hyperplasia, and you could suffer with that. And you can even end up getting urinary tract infections and obstruction, and you don't want the old-fashioned TURP where they have to bore it out. We have UroLift, we have a lot of other opportunities and other things that we could use therapeutically. Work with your urology doctors. Tadalafil is a great medicine, kind of like an alpha blocker like alfuzosin and doxycycline, and the old school tamsulosin Flomax, which is probably not the best, guys. So you want to use more tadalafil, not medical information. Here, you want to also always ask your doctor to work with this, because the side effects of these BPH medications are on the cardiac system, because they're not great blood pressure medicines, but they affect blood pressure, and it could be irregular, and you could get dizzy. And I've had some horror stories I've heard of guys coming in for consults saying that they were on some of these medicines for their blood pressure, actually, funny enough, and for the prostate, BPH, and they're walking out with 405, or even one guy up to 900 out of the racks, and just getting really dizzy. So you got to be very careful with that. Maybe the time of the day of taking that is going to be really important, and work with your doctors. So to conclude this presentation from head to toe, I think it's not 400 milligrams a week of testosterone. I don't think is sustainable. I've seen maybe a handful of guys that have lived on that for maybe 25 or 30 years. It's really true. Some of the old school powerlifters coming to me in the last 10 years or so, and but they had health consequences, right? So they had the heart issues, definitely had the prostate issues, and we had to work around that. So what I'd recommend is that you probably don't want to live on that much, and if you're on that much, the good news is that you can wean down with a great physician, healthcare provider, or you may have to just do it yourself now with help with the AnabolicDocApp.com, and use your resources and go down to the lowest effective dose, so you could make sure that you could live a long, great life and still feel great on testosterone and have great sex and feel great energy, but you're going to protect your libido, you're going to protect your heart, your central nervous system, depression, anxiety, not have a DVT, and minimize the exposure of androgen to your prostate. All right, guys, let's get a lot of great comments on this, because there are so many men, millions of men actually in the world, that hopefully will see this and will understand this is a brotherhood. So look at the comments. Give us the comments. What are you on, guys? Have you lived on 400 or more? What happened to you? What did you experience, good and bad? How long did you do it? What was the rate limiting step? Why did you go down? So I really hope this helps so many brothers in the world to stay strong and healthy. Thank you so much.